talked about. Rate versus rhythm, one isn't better than the other. Just make sure that your patient is comfortable on whichever regimen you choose for them. And now what we were looking at is our patients who had AFib. Remember that you're always going to look at that CHA2DS2-VASc score. I don't need you to remember everything that goes into the CHA2DS2-VASc. I will give you a number and you will say, do I need to anticoagulate this person before trying to cardiovert or putting them on their medications, or can I not give them the anticoagulants? Okay, so I just need you to remember that chart at the bottom that was telling you the difference between your men and your women. If you get a number, what you're supposed to be doing with them. So now you see again our rhythm control. This was a lot of the stuff that we were looking at already. So our 1C, and remember we said pill in a pocket approach. So anytime that patient starts to feel those flutters or they start to feel the symptoms that they have with their AFib, they would just take one of these pills. Okay, so again, remember you have your flecainide, your propafenone, making sure that those patients do not have structural heart disease. We will get to the portion of this where if they do have structural heart disease, we're going to treat them a little bit differently. We talked about that CASH trial already and saying that these things can be pro-arrhythmic and causing arrhythmias, even though we're using them to treat arrhythmias. So making sure that we're, that initial dose they should be given, but the ones that they have to be hospital for the extended period of time, we've already kind of looked at those. Make sure that you're understanding the length, the duration, the window that you have, because that could be something that you definitely see again. Contraindications, same thing that you already saw, right? If they have structural heart disease, we're going to change what it is that we're doing and how we're treating that patient. Class 3 agents that we have, you have your amiodarone, again, that we've already talked about. So with this was one of the ones that I was telling you, we do initiate this when the patient is in the hospital, but it's also a lot of that because of the big dose that we have to give. So it depends on what the cardiologist wants to do. We do have an oral formulation of amiodarone to where you could load them outside, but most of the time when people have AFib, especially if they're not symptomatic and we're wanting to put them on treatment, we can do this in the hospital for them. So we can initially start them on IV and then change them over because of the fluid, the amount of fluids that we have to run, because you see 10 grams is a lot. So you can, different ways, several different ways for you to get to the 10 grams. So I just want you to remember that they need to have a loading dose of 10 grams. If you have a patient who comes into you, and let's say they're still in their loading dose phase, you need to make sure that once they get close to it, and cardiology will be monitoring this patient very closely as well, but that they're not still taking their loading dose regimen, because that dose is going to drop drastically once they get on their maintenance dose. So 200 versus how you're seeing that they're taking that 400 2 to 3 times a day, right, to get them up to that 10 grams. So some patients, because they're used to taking it that way, they will continue to take it that way even though they're supposed to be in their maintenance phase, okay? So I just want you to remember that you have the loading dose of 10 grams. Once your patient has been on it for a long period of time, you just need to make sure that they're taking it the right way. And the way that you make sure that they're taking it the right way once they have been loaded, is you ask them, hey, how often are you taking this? Okay? Let them tell you, don't you tell them, because they're going to say, yep, that's what I do. I only take it once a day. When in actuality, they could be still taking it that 2 to 3 times a day. Very effective medication, long half-life. This was the one that we talked about, all of the different monitoring parameters, all the different interactions that it had. So just, again, make sure that you're running it through that interaction checker. What do I want to say? Other things about this. Those are your big things that you're looking at here. And then you see here, safe in our heart failure, which is not what we were looking at when we were talking about our 1C drugs that we had. Dronedarone, you see like what we were already talking about before, not as effective as our amiodarone, so you see that number drop. Just know that it's not as effective as our amiodarone. Remember, I told you I don't want you to remember the percentages. You also have your sotalol. Remember, it's not a class 2. That's your one that has those beta blocker activities, but it is in the class 3. And then your dofetilide, again, pretty effective medication. Just depends on how what your patient wants to do and how they respond to the medication. And then again, this has a summary of all of your ones that are initiated in the hospital. Again, most of the time when people are taking their first dose of most of these, we are monitoring them whenever they do it. And by we, I mean cardiology, not you or me. But you can see situations where it's not a must or a black box warning as to why it's having to be initiated in a hospital setting. So just go over this and look at this so you can see who's in the hospital, who's not in the hospital. And then also as you're going through this portion, make sure that you're paying attention to what is safe for your heart failure patients, which ones are not safe for your heart failure patients, and then looking at structural disease versus not having structural disease, okay? Because those are the three big things that will determine which medications we are going to use when we're talking about our AFib patients. And then your ibutylide also listed here for us. We saw that one already as well. So your special patient populations that you have. If a patient has heart failure, our 1A and our 1C, we don't want to use these. You saw this when you were in your previous block. You just didn't know what 1A and 1C was talking about. Now you know what your 1A and your 1C are. What's your mechanism of action for your 1A and your 1C? Sodium channel blocker, okay? So make sure that you're remembering that. So when we're looking at these, you have your amiodarone, dofetilide, and your sotalol, which have a neutral effect when we're talking about our mortality benefit, especially if they have already had that MI. So just paying attention to what these effects are. If somebody is not stable in heart failure, so let's say they're in acute decompensated heart failure, or if they have heart failure and they have not already been placed on the beta blocker, and now you're seeing that they're showing up and they have AFib, don't start the beta blocker in that situation, right? We need to make sure that our patient is stable first before we start that beta blocker. So that's why I say if unstable, avoid or hold the beta blocker that that patient is already on. And if they are on the beta blocker, we should be holding it. Your dronedarone, when you're looking at this, just make sure that you know don't do your dronedarone in your patient who have heart failure. And then your acute MI. So again, 1A and 1C. Remember we talked about 1A and 1C and just class 1 in general. 1B were the ones that, what was the unique thing that 1B had? What kind of clinical use could you see it used for? Pain, right? That was the different thing that we had about 1B, and we don't often use it whenever we're looking at these situations, but we can. So when you're looking at that 1B, that's why a lot of the times you don't see it as the thing that's excluded in class 1 because we're not typically using 1B very often. And then looking at this, you can see that when we're using these classes or these drugs in 1A and 1C, that they have that pro-arrhythmic effect, which is what we saw with that CASH trial again. And then your amiodarone and dofetilide, again, that neutral effect that we were talking about before. So just saying that it's not very beneficial. We didn't see a lot of improvement. And then looking at some of them, sometimes we can see where it could potentially be worse and it could cause them to have torsides and different issues. So being very aware and making sure that you're looking at, if you have a question on an exam, making sure that you're looking at that heart failure, making sure that you're looking at an MI patient and understanding which drug classes you're avoiding in those patients, okay? That's going to be the name of this game. So we kept looking at this and you're hearing it, so now this is like a succinct chart for you to kind of go over and see what's happening when you're talking about the structural heart disease versus not. So here, my patient does not have any structural heart disease, so I have two different routes in which I can go. Y'all are going to talk about all of the different things with heart disease and all of the rhythms and everything. So for me, I'm focusing more on the drugs, and I'm just going to tell you, like, they do have structural heart disease or they don't. So you're literally just remembering, yes, structural heart disease or not, because you have not had all of this stuff in cardiology yet. So no structural heart disease. You see that your 1C and your class 1-3. Ibutylide isn't on here, but you could also potentially use ibutylide in your non-structural heart disease patients. I'm not going to ask you about a catheter or an ablation because that has nothing to do with drugs. So where I will be asking you something is going to be here. If you are not seeing an adequate response for your patient, you can go to amiodarone, but you see amiodarone is further down because I have more monitoring. those side effects, it's a lot more work for me to do versus me starting them on one of these. So not really worried about you knowing about an ablation or any of that, okay? My concern is over here. When in this side, your dofetilide, all these in your amiodarone. So if I have structural heart disease, you see that I have my coronary artery disease and I have my heart failure. When you're looking at this, this is again where I'm worried, right, about you knowing. So looking over here and saying, hey, I can use my class 3. There's no 1A or 1C that I'm using here. So my class 3, and I'm avoiding my dronedarone in my heart failure patients. So over here, you see the same thing, right? I can use my class 3, but the only one that I don't use is the dofetilide because if my patient had heart failure, okay? So class 1C, class 3 over here, ibutylide should be also on here because you could potentially do that with your patient who has no structural heart disease. Your patient who has structural heart disease, if you're looking at coronary artery disease, class 3, okay? If you have heart failure, then you're looking at your class 3, but you're avoiding your dronedarone. You can't use that one, okay? So this is summarizing essentially what we saw in all of these, where it was telling you when you can use it, when you cannot use it, and it's a picture of this previous slide that was in front of it. Okay, 65-year-old male comes to your clinic for drug monitoring. He's taking amiodarone. Which of the following would you perform? All of them, right? So remember, we had 5 things that we were looking at when we were dealing with our amiodarone, and then making sure that we're getting these at baseline, and then if our patient complains about it, we're getting it again. Okay, we're going to take those levels. We're not going to tell them, well, it's not time yet. We haven't hit that 6-month mark yet. We're going to get those levels. Over here, what you see is what the type of arrhythmia is that that patient could present with and what your drug of choice is. This is what I want you to know, your type of arrhythmia and your drug of choice, okay? So when somebody has a symptomatic bradyarrhythmia, you see that we can use our atropine. You talked about your mechanism of action previously, so I'll just tell you to remember the whole chart just in case somebody doesn't remember. So we talked about our atropine and how it was an anticholinergic, okay? So that's the big thing that you're wanting to know here. If you remember anticholinergic, you kind of have your mechanism of action. And then looking at your comments or your adverse effects that we have, anticholinergics are going to be the things that, like it's drying everything up, right? So that's where you're seeing a lot of this. A lot of your side effects here. Your PSVT, so again, we already talked about this, our on and our off switch, right? You're turning something off, and then it's going to be restarted. This was the one that we said had that very, very short half-life, and we were going to flush right after we gave it to make sure that it gets to your patient. So here, same mechanism that you already seen before, bless you. And then these are alternative treatments. Don't need you to know that, so don't worry about this over here, okay, for this one. Then you have your ventricular tachyarrhythmias and your pulseless fibrillation. You see that you have epi. That was one of your options that you can use. And then we also have our amiodarone. Again, this patient, if they were on the amiodarone, they're going to be in the hospital if we were doing this. And they're likely in the hospital because of their situation, right? Hopefully they're around some medical help. So this, you see the slow IV bolus, and then they will keep them on essentially a drip or an infusion until we get them back into that normal sinus rhythm. I'm not going to ask you about 2nd, 3rd, and 4th line, so you don't even have to go over here on this one. And then your torsades, remember this is something that can be caused by a lot of our medications that we put our patients on, and sometimes they can lead to death, especially if we don't know that they are in this rhythm. What we had was our magnesium, and that was another thing that I meant to tell y'all. On the magnesium slide, it doesn't have torsades on there as a clinical use. I was talking to somebody yesterday, I don't remember. And we saw that that wasn't on there, so just make sure that on your magnesium IV slide that you put that you can also treat torsades on here as well. We already know what our mechanism is. Not going to ask you anything over here on this one, okay? So on here, you're only looking at your type of arrhythmia and your drug of choice. On here, you're going all the way across, and on here, just your type of arrhythmia and your drug of choice. Okay? This is just some of the medications that we have. So remember, our torsades was at the the rhythm that I told you that could happen from some of our medications that a patient would take. So a lot of these, right, were the things that we hit in this lecture. And then previously last semester, the way that we would say it was like, oh, we're having some minor issues when we were looking at our macrolides, our fluoroquinolones. We were saying, hey, you can see some of that QT prolongation and things like that happening in our patients. This is what that was referring to back then last semester. So antidepressants, anti-psychs, anti-migraine. If you see these, I would tell you like, hey, this is what drug class it falls in to help you, bless you, kind of remember where they go, okay? All right. What class of antiarrhythmic did we have for our lidocaine? 1B. What other drug fell in the 1B class? Medicine. Mayo. So that was our oral formulation that we had that's also in our 1B class. Sotalol initiation requires a week-long monitoring whenever you're initiating it. True or false? How long do we monitor them when they're using their sotalol? I know y'all are studying for EKG, but I need y'all to answer me. 1 to 3 days, okay? How is your adenosine push? Fast. Okay, what is the dose the first time you try it? And then the second time? And then what are you following it with? Your blood. Okay. Dang, y'all. Okay, we have a guest that's in the back who was about to teach y'all. Can we like balance the studying with the answering questions? Because y'all have cases when y'all are going through this, okay? Through your pain lecture. And it's a big portion of your exam. All right? So she's going to go through. Your memory joggers are still on here, same things. I will be around for you guys. I'm going to try to go and see if I can get them to fix this heater because they're like really trying to cook us and this is not going to work. So I'm going to be walking around the building to see who I can talk to. In the meantime, you're about to have your wonderful part 1 and 2. Is it 1 and 2? Of pain. It's not meant to be painful, okay? You can come up. And we will get you guys situated. Let me get her logged on first, and then I'm going to see if I can stop getting us roasted in here, literally roasted.
Yeah, so basically that is have a lot of part 1. Yeah.
But what makes the wavelength is that wide on 1, 2, 3, right?
So it doesn't. So like it doesn't. So this, yeah, this
Get 100 slots
So how do I know?
for her first one.
yeah.
But if it were to be, I guess my question is, if it were to be just wouldn't it go over?
Yeah.
So if I only see it on my 2, then that means something.
Yeah. But like it doesn't take your study.
69.
Yeah.
Huh? 69 part 2.
But you gotta be careful because the tax
Oh my lord.
it's a little more
2 pages of abbreviations.
Look at this. That's what it looks like. Look at that. Look at that. Look at that.
He's like en route
How rude.
You're still trying to survive.
I'm trying to survive.
Puppy cigarettes.
Do you think the states are gonna be fine?
Can you remember who brought it up? Tomorrow? Is that tomorrow?
First of all, who eats dates? Señoras, los abuelitas.
It makes great milk.
Great. Not good. Not okay. Great. That's what people want to eat. Is that going to be your, you know how we went over the,
We always eat from one to
you know how we went over the everyone, if you give like preventative stuff, eat a steak.
Prevented, eat a day twice a day.
Eat a date, wear your seatbelt.
Wear your seatbelt.
Don't do
Put on
drugs.
sunscreen.
No sex before marriage.
Just
Whoa. What?
no zip.
It's preventative.
Preventative what, dying?
Dying. STIs.
Still get STD if you're married.
It's like you see it.
Alright, we'll go ahead and transition over to our pain lecture series. So this is roughly half of the exam, are going to be all your pain lectures. Okay. Alright, so my name is Nicole. I work over at BMC, been there about 6 years now. I work in our pain clinic. I also work with our palliative care team. So kind of a mix of different patient populations. My background is I'm a pharmacist. But I specialized in pain management and palliative care, so I did residency for that. I was at the VA when I was doing that, so lots of good experience, lots of different things. This is my second time coming back and working with you guys. I work with the occupational therapists. They have summer courses, so I do some of their ed lectures. So lots of fun things. Because I am civilian, know that these are my thoughts and opinions and don't represent the government. There's lots of different abbreviations. All right, the objectives here are the ones that are stated in your syllabus as well. So we'll be targeting these, remembering that whenever we're looking at our medications, we're thinking about mechanism, uses, any side effects, contraindications, different interactions, routes, and then pertinent counseling. For part one, so this first slide deck, we'll talk a little bit about the background, what is pain. We'll talk about some different meds, kind of why do we choose the things that we choose. We'll go through a few patient cases, and then we'll conclude that piece. The second half of this first part, we'll then talk about non-opioids, so going through different herbals, topicals, and then our NSAIDs, and then wrap that up as well. So to start, what do we know about effective pain management?
Marrying him.
What was that? It's important to control. Okay. So pain is the patient's problem. I'm going to switch that to say pain is the patient's perception. Okay? So that's part of the definition of pain. Okay? How I perceive pain is different than how someone else perceives pain. Okay? What else?
It's a self-perpetuating cycle.
Okay? Cycle. Right? Keeps happening, keeps growing. Okay, what else? That's it. How about med-wise? Okay. What else? Addictions coming up. Okay. Specifically regarding what? Opioids. Okay. Okay. Loading doses, maintenance doses, right? We're like tying in some of these AFib concepts too. Okay. That's it, just like opioids, it's the patient's problem, addiction, the end.
Respiratory issues.
Okay,
Liver metabolism.
okay. What about the drugs that we're talking about today? There's lots of other things, right? So we got herbals, we got topicals, we got NSAIDs just for part one. We got Tylenol, antidepressants, anticonvulsants, right? So we got all these other things. So making sure that we're using this toolkit and using it appropriately based on the types of pain that patients are experiencing and perceiving. Okay? So as a little refresher, we have different types of pain generators. So we have nociceptive, which is a body tissue damage. We have neuropathic, which is some sort of nerve damage. Psychogenic, so a psychological factor, and then malignant, which is cancer-related. When looking specifically at nociceptive, that body tissue, it is divided into two other categories. So somatic would be things like your bone, skin, joint, you twist your ankle. That's a somatic type of pain. Visceral pain are going to be our organs. Okay, you have a stomach ulcer, that's a visceral pain. You can't say that, oh yeah, my stomach hurts right here and the ulcer is right there, right? Where you can do that if you hurt your elbow. So visceral is very non-specific when we're thinking about descriptors for it. Neuropathic pain are going to be things like diabetic neuropathies, phantom limb, radiculopathies. Thinking about our burning, shooting, radiating, tingling, stabbing type pains. And then thinking that pain also has different durations. So we divide it into acute, subacute, and chronic based on the duration. We also think of the severity. Severity is always going to be a 0 to 10. What is your pain? Okay. Oftentimes I hear 1 to 10. What is your pain? Right. So always recommending that 0 is still a pain score. That means that they have no pain. How pain works in the body. We think of 5 steps. Okay. First, we start at the site of injury. Okay. Something has to happen. You touch a stove. Okay. That feeling needs to get to the nervous system. Okay, so first we have transduction. It goes into those peripheral nerve endings. Then it has to get all the way up to the spinal cord. So now it moves, it conducts up to the spinal cord. From there in the spinal cord, it has to tell your CNS, hey, this is happening in the periphery. So within your spinal cord, we have this neurotransmission. Okay, that then goes up to the brain. The brain perceives what just happened. The brain then sends some sort of response. So take your hand off the stove. Okay, and then it can also modulate that pain. Yeah, you know what, Nicole? Now your hand is bloody and bruised and burned and all these things. We're going to help give you some natural opioids in your body, some natural anti-inflammatory things to modulate what that pain feels like. Okay. The next slide is the exact same thing in picture format. So step 1, we have some sort of injury at the tissue site. So transduction. That then goes up to that dorsal horn in the spinal cord. We have our conduction. That message is translated in the spinal cord, neurotransmission, and it goes up to the brain, where the brain then perceives that you're having pain. When you have pain, you get that response and modulation. And we can have a correct response of ouch. Okay? Why do we care about this in a pharmacy lecture? Because this is where all of our drugs work. Okay? So throughout this picture, and when we're thinking about when we're treating folks' pain, we don't always want to treat something that's just going to change their perception. Right? You just think that you have pain, it's fine. We're just going to keep giving you brain meds, you're good. Okay? We need to be targeting areas throughout this pathway. So there's different medications here that are basically kind of listed throughout this pathway as well. Here. Questions so far? Okay. So looking at transduction, so at that skin level, what's happening, getting to those peripheral nerves, we have all of these different neurotransmitters. Okay, we have some prostaglandins, we have lipid things, we have histamine, bradykinin, serotonin, all these different things that are sending this message. So for some of our medications that are going to inhibit these things, we're not going to be able to have that signal transmission or transduction. Okay? As it goes up, it conducts to the CNS. Now we're getting that transmission in our spinal cord. Modulation is also happening in our spinal cord. When the brain says, hey, let's not do this anymore. Okay, so we're modulating what that signal is when it's being, during that transmission process. So we can interrupt that signaling. We're gonna focus on enhancing inhibitory neurotransmitters because we want it to stop sending that signal. And we want to suppress excitatory neurotransmitters. I know this is like a double negative. We're still with me? Not seeing a lot of, see some yeses, some yes, cool, great, love it. All right, here's one example. So NMDA with glutamate. So NMDA is a specific drug class and mechanism that's in a couple of our different medications. So we have our presynaptic neuron, our postsynaptic neuron. This is going to be in our CNS that we're mainly seeing this mechanism. So we're going to have glutamate. It's going to go down. It's going to bind on an NMDA receptor. We're going to have that influx of calcium. We're going to continue that action potential. Okay? We don't want pain to keep going. So we want to inhibit this process. Okay? So we can actually use magnesium to plug that site. Glutamate tries to come over, glutamate can't bind. So one of our natural products that we can actually use is magnesium, theoretically because it's going to help be a magnesium plug naturally at this receptor. We can also give it an NMDA receptor antagonist, so medications that sit in that receptor site. So they come and bind, that glutamate tries to go, it's blocked. So we don't have that signal of pain moving up to the brainstem. Okay. So to refresh, we have this ascending pathway of pain, we have a descending pathway of pain. Okay. Different things are going to be helping throughout that pathway, different medications, different receptor sites. Questions on pain overview? Okay. All right, meds. So when we think about what meds to choose, we need to think about both medication considerations, but then patient considerations. So medication things, how does it work? Where does it work, right? So things that we just talked about. What are some side effects? Okay? Things that are part of that syllabus objectives. What are some pertinent pharmacokinetic or pharmacodynamic principles? Any drug-drug interactions or drug-disease interactions? Okay? If someone has heart failure and they have a fluid issue, can they take this medication with it? Different dosage forms. Can the patient swallow? Cost and availability. Certain patient conditions that we would think about are going to be the type of pain that they have. They have nerve pain, but we're treating them with something that's going to help with somatic pain. Those aren't going to be the best thing. Okay, so making sure that we're targeting the type of pain they have, whether it's chronic versus acute, what other comorbidities they might have, if they have any adherence concerns. Are they a teenager and they forget to take their meds every day? They don't want to take something every day. Are they elderly? Do they have dementia or delirium? Aberrant concerns. Are they at risk of misusing different products? What is their age and physical size? What does their support system look like? What is their dexterity? Can they open a pill bottle? Can they open a tube of cream? Can they peel off a patch? Can they place a patch on their back? Right? All those different things are going to help depend on what medications we think about. General understanding and then financial status. Again, so broad overview, remember that we do have CYP pathways. CYP pathways involve a lot of our drug interactions. In our body, this is where the majority of CYP pathways function. The biggest one being 3A4. Okay, we have some medications that are notoriously going through that 3A4 pathway. We have some inducers and some inhibitors. What's the difference between an inducer and an inhibitor?
Speeds up and breaks down.
Okay, speeds up or reduces metabolism. Okay. What's the second most common one? The biggest time chart? Yeah, CD6. Okay, and again, we have some others that function at that area as well. We have some prodrug substrates. What's a prodrug? See lips moving.
Goes in there and
Yeah, so it's not the most active initially, okay? So tramadol is technically active initially. Its metabolite is 300 more times more active, okay? So we kind of consider it a prodrug, okay? Codeine, it goes to morphine. Morphine's the one that's doing the work for it, okay? All right, we get to our first drawed in. So controlled substances, they're classified by both the FDA and the DEA. We have two categories when we think about controlled substances. So one is the medicinal use or medical use, and then one is the risk of physical or psychological dependence. So which ones, what do you guys remember about these? C1 through C5.
Class 1 is not there.
Okay, so one of these classes is illegal, is illicit. Show of hands, your options are either, is it C1 or is it C5? Okay, who says it's C1? Who says it's C5? It is C1. Okay, good. So which ones of our C1 through C5 will not have a medical use? C1s. How about all the other ones? They have a medical use. Great. How about physical dependence or psychological dependence? Yeah, highest risk, lowest risk. Okay? All right, when thinking about routes, we have things like topicals. They're going to be locally acting. I put something on my arm, it's only going to help on my arm. Transdermal is I put it on my arm, it gets absorbed systemically. Okay, fentanyl patches are an example of a transdermal application. Testosterone is transdermal application. You apply it, but it goes into the whole body. Oral medication, sublingual, rectal, sub-Q, IM, IV, and we also have intrathecal. Have you guys seen intrathecal pumps? Lucky for you, I begged my docs for an extra one. So these are examples of intrathecal pumps. These are implanted into the abdomen. They feel like a hockey puck. They normally don't rattle. Okay, my doc was a little rough with his. But they are implanted into the abdomen. There's tubing that extends from this device to go into the spinal cord intrathecally. Okay? I'll pass these around here in a second. On the front, you'll see there's a little button that looks very much like the top of a vial. Okay, like you're doing a flu shot vial type thing. So it's kind of that rubberish tissue. These are just pure metal, okay, for demonstration. These are also slightly different sizes, and that's just because they're different volumes. So we can put medications into these pumps, and they are going to infuse slowly straight into the CNS for patients. Okay? What would be goods and bads of having this as a route? Compliance. Okay, compliance is better or worse? Better. Yeah, they don't have to remember to take medications. Good.
Goes right in your spine.
Goes right into the spine, so what would that help?
Good and bad.
Good and bad, okay. So potentially our dose is going to be a lot lower because it's not going to have to go through the liver and go to other organs. Like, it's just going to go straight to the brain. Okay. What else? These are good things so far. Put them in everyone. Right? What happens when you run out?
You access it like a port.
Yeah. So what happens when you run out? You have to come back in and refill it. Yeah. So these, depending on how frequently folks use it, the fastest I've seen was about 3 weeks that they had to get their pump refilled. Our patients we bring in every 8 weeks, but most of them could get by every 3 months. Okay. What else do we have to be cautious of when thinking about the medication that's in these pumps?
Clogging.
Cost. What about how they're made? Sterility, okay, right? We don't want to be injecting meningitis straight into the brain, okay? Things that have preservatives, we can't be putting preservatives into the brain. Okay, so a lot of those factors do come into place as well. So hypothetically, you're on rotations, right? Pretty soon, you get a call, hey, there's someone that has like this hockey puck in their stomach. And you're like, oh, pick me. I know what it is, okay? So that's my hope that we can talk about some of the different tools that we use for these different pumps. I was on one of my clinical rotations as a 4th-year student, and we also got this call of, we've never seen this before, but it's like this random hockey puck. So in our clinic, we have maybe 9 patients who have these. So very low utilization. During the height of the opioid epidemic, 10, 15 years ago, I would say, this was something that a lot of docs were turning to, right? No more opioids on the street, find a different way. Oh, we'll just implant it, okay? So a lot of the folks that get these are gonna be a little bit older or have had a prior significant use of oral therapy. So have those, keep passing them around, and I'll pick them up at the end of the hour. All right. When thinking about different medications, right, we have herbals and supplements, topicals, NSAIDs. NSAIDs will classify into how their main mechanism is, whether it's a COX-1 or COX-2 selective. We have acetaminophen or Tylenol is its brand. Antidepressants, commonly for pain, we're going to see SNRIs and TCAs. Anticonvulsants, we have gabapentinoids, some of our more traditional products like oxcarbazepine, benzos, and then topiramate. Muscle relaxants, we classify this as either spasms or musculoskeletal concerns or spasticity. Other considerations are going to be things like our NMDA receptor antagonists, suzetrigine, and ziconotide. Ziconotide is another one that only comes into that pump. And then we have our lovely opioid class. So how do we pick between these things? Well, the CDC made a lovely statement saying, persons with pain receive appropriate pain treatment in careful consideration of the benefits and risks of all treatment options in the context of the patient's circumstances. Clinicians should collaborate with patients when making treatment decisions and designing a treatment plan, including when initiating or changing pain management strategies. So what should you do? Talk to your patient, okay? So this is one that there's not going to be a black and white for pain. Okay, it's really going to depend on every single patient. I could have a patient come in with the exact same pain, and I could treat them all extremely differently based on other factors. Okay. All right, you guys may be familiar with this thing called the WHO ladder, WHO analgesic ladder. So this was brought out in 2008-ish, was kind of the height that it started being used again around the time of the opioid epidemic, which stated that as we go up in step, we add stronger and stronger treatments. The WHO ladder is specifically for cancer-related pain. So that's a big misconception of its use. And it's solely based on pain severity. Okay? So what does this mean? I have lung cancer, I come in, I say, hey doc, my lungs hurt, my back hurts, all these things, I have mets everywhere. Do I get opioids? Maybe, okay. My pain is a 8 out of 10. Do I get opioids?
Maybe.
So probably, okay. Now we're just like, oh, maybe there's more factors, right? Aberrant behaviors, who knows? Okay. I have lung cancer, I have mets everywhere, I just fell and rolled my ankle, and my ankle is now broken. Do I get opioids automatically? No, why? It's not cancer related, it's a secondary pain, okay? All right, so again, limitations is it really appropriate in non-cancer related pains? And then making sure that it's really not limited per patient, right? So just because I have lung cancer and my pain's at an 8, okay, well you have bone pain and maybe that's better treated with steroids or something else. So they tried to revise it to say, okay, now it's a platform. Instead of saying that we just increase and you automatically get opioids in addition to other things, now opioids are a part of the whole step. Okay, so you could have opioids or all these other things, not opioids and these other things. Okay? To me, I think this is still misleading. Okay. So what do guidelines look like? So these are example guidelines. I will not be asking you to, per the general guidelines of musculoskeletal 2020, blah, blah, blah. No. Okay? But this is for your knowledge of when you're trying to make these decisions as a clinician, what do the guidelines really look like? right? CDC said make your best guess. The guidelines are also pretty much saying make your best guess. Okay? So for this example, in 2020, there were guidelines put out for acute musculoskeletal injuries. So you roll your ankle and different things. They say strong recommendation for a topical NSAID, weak recommendations for topical menthol, Tylenol, and NSAIDs. And they recommend, or they suggest against opioids. They don't talk about anything else. Okay? In 2021, they came out with guidelines for chronic primary pain. They said maybe try an SNRI and maybe try an antidepressant, or a TCA antidepressant, but nothing else. Okay? Here's examples for low back pain. And just seeing the differences in the first two columns, we see acute low back pain. The next two columns, we see chronic low back pain. The NICE 2020 guidelines are for specifically sciatica, which I do always love to point out that for gabapentinoids, still a strong against. My docs still do it. And then low back pain for the last one. Okay, just general low back pain, 2016, it's a little outdated. So again, there's kind of this wishy-washy, there's no strong fours, anything. A lot of my patients can feel disheartened when I tell them, you know what, you have this low back pain, I'm really sorry that you're going through that. There's really only two things that are kind of suggested for that. Right? So let's work together, find something that works for you. The guidelines don't really say that we should be using acetaminophen, but this is what I've been seeing for my other patients. Or because of these characteristics, this is why I think I want to put you on acetaminophen. Okay? So lots of different factors. When we think about, again, how we're treating, we're going to determine the appropriate assessments for the patient, see if there's any red flags that are happening for the patient. Where is their pain? How long have they had it? How severe is their pain? Opioid therapy is primarily going to be reserved for severe acute pain. I roll my ankle, it's a 5 out of 10, too bad. Okay, it needs to be 7, 8, 9, 10 out of 10. It needs to be severe acute pain to really be considering non-opioid. Cancer-related pain. So again, just because someone has cancer doesn't mean that they get an opioid. It has to be pain related to their cancer. If someone is on palliative care or receiving end-of-life care or hospice support. Patients that have opioid dependence. This is going to be specific types of opioid therapy that is approved for that. So if they have some sort of addiction. And then if they have severe refractory chronic pain, so they've tried everything, maybe we might consider an opioid. This is still very controversial whether or not we're going to do this. We can also encourage patients to keep a pain diary. Okay? It's exactly as it sounds. Write down how your pain is, when you take your meds, what are you feeling, how long does it last for, when does it come back, what triggers it. So looking at both subjective and objective changes to that dosing, reassessing for both efficacy and tolerability of those treatment options, and then modifying as necessary. Okay? So we have Alex. 43-year-old presents to the emergency department, severe diffuse abdominal pain and low back pain, which have been awakening him from sleep. Imaging is significant for widespread osteolytic and osteoblastic lesions, and asymmetric, I can't talk today. Yep, I can't. Colon wall thickening. So what might be going on with Alex? Might have cancer, right? What might we do for him? We might consider opioids. Okay. All right, we have Miss Maya, 22-year-old female, presents with mild pain following sport-related injury, which occurred last night at intramural soccer. Her imaging is unremarkable, and she's diagnosed with an ankle strain and is advised to rest, elevate the ankle, and apply local cool compression. What are we going to do for her?
Nice.
Opioids, non-opioids? Non-opioids. She has acute pain. She has an injury. It's not severe. Okay? Not severe. All right, good old Scott, 48-year-old, 5 out of 10 pain, chronic axial low back pain. Recently completed imaging that was remarkable for age-appropriate degenerative changes. He finds it difficult to stay motivated to complete his home exercise program and has historically not been interested in medications as he would rather, quote, tough it out. Right? Military history? Opioids, non-opioids. Non-opioids. Okay. So we have chronic, non-cancer pain. It's axial. What type of pain would that be? Body, okay, so neuropathic, nociceptive. Right, so it's a nociceptive type pain. Is it somatic or visceral? Somatic, okay, it's a bony structure. Right. And then little Milo, 10-year-old male undergoing extensive dental procedure. The pain from the procedure is expected to be severe and persist for a few days following the procedure. Milo will initiate non-pharm interventions of local cool compression and rest. Opioids, non-opioids.
Consider it.
Ooh, we're kind of split.
Lidocaine.
Yeah, lidocaine, right?
Stomach. Can't feel it.
Okay, so maybe ask him a little bit. Right? He's already in braces. Now we're going to get this expected severe pain. It's only going to last a few days. So this is a patient that would be appropriate for a short course of opioids. Okay? It's acute pain. It's severe. In summary, pain is subjective, right? While it may be the patient's problem, it is still subjective, and we do have to respect that. It's a personal experience that should be respected. While pain may be adaptive, it is negatively influencing function, social, and psychological well-being. The nociceptive pain pathway involves transduction, conduction, neurotransmission, perception, response, and modulation. And treatment approaches may vary based on this assessment, and guidelines that are used and further therapeutic selection should be based on patient-specific factors. Questions with this first mini part? Okay, makes sense. We know opioids, non-opioids. Who ladder? Do we love it, hate it? Indifferent, okay. Typically, my view is that I kind of hate it, right? So not the ladder, but what's the other one that might be a better option? The platform. Okay, the platform, right, where they're all equally reasonable options. So now we're going to go through different herbals and supplements, topicals and NSAIDs. Let's go through one section and then we'll cut for break. You guys started what, 12:30ish?
12:20.
12:20. Do you want to break now or do you want to do another mini section? Mini section. Okay. All right, supplements and herbals. Bottom line up front. There's limited clinical data regarding commonly used supplements and herbal products for chronic pain. It's patient and provider preference. Okay? So the exam question isn't going to be like, which one option is the best treatment option for this patient, right? Because it's like, there's not really good data. Okay? Agents are not regulated by the FDA. So that's saying scrutiny. So we don't really know the purity of the products that patients are getting. Today we had a patient, one of my docs was asking about their kidney function is horrible and they're very young. Turns out that they're using different like supplement protein powder things that are all appropriate, but those aren't regulated. Right? And so having that conversation, unfortunately, with the patient, we don't know what this is from. We're going to keep working it up, but in the interim, like let's stay away from things that aren't regulated. There are different seals that you can find. So these are 3 examples of different seals that you can find on bottles. Whenever I have patients that want to do herbals, I just always encourage them that they have some sort of purity seal on the prescription that they're giving or on the product that they're choosing. 5 agents that we're going to talk about. They're, I would say, commonly advertised and marketed. Alpha-lipoic acid in this list is our only one that's for neuropathic pain. All the others are for nociceptive pain. So fish oil, glucosamine, magnesium glycinate, and turmeric. Which one of these have we already talked about for this exam?
Magnesium.
Okay, apparently magnesium. What other one? Which one?
Fish oil.
Fish oil, thank you. I was like, you guys talked about one on Monday. So fish oil, okay? So alpha-lipoic acid, ALA, comes in very natural sources. So organ meat, spinach, broccoli, tomatoes. This would be considered a supplement, okay? It would supplement your diet. So if a patient has a good, well-balanced diet, I don't recommend that they take additional supplements, okay? Mechanism is that it's a free radical scavenger, so it's going to help with antioxidant properties. It's going to be used for neuropathy. Side effects, it may cause a GI upset, and then hypoglycemia. So what types of patients may have neuropathies?
Diabetics.
You guys are really good at saying the exact, like different things at the exact same time.
Diabetics.
Diabetics.
Okay, patients that have diabetes.
Diabetes.
Okay, so they may have peripheral neuropathies. Okay? Based on our side effects, it could be good or bad. This is a medication, we hope that, or this is a herbal product, it could help with some of these nerve pains that you're experiencing, but it may lower those sugars a little bit more. We want to make sure that we're using those safely and appropriately and that you're appropriately checking your blood sugars. We don't want you to get too hypo. Nervive is a commonly advertised for anyone who has cable still that you may see. And so we can see in it, it does have alpha-lipoic acid. Omega-3s, so fish oil, krill oil, cod, and all these other different types of oils we can find omega-3s in. These are going to be anti-inflammatory. Mainly we're going to use it for, again, more of our nociceptive pain pictures, so arthritis, and then we can certainly use it for our cholesterol lowering, so triglycerides and our VLDLs. Side effect, though, is that it can raise our LDLs. All right, don't forget that one for lipids as well. We do have drug interactions with warfarin because it can increase bleeding risk. So caution in folks that have bleeding disorders as well, and certainly fish allergies. Next one, glucosamine. So this is actually from shellfish, or it could be lab created. It's a cartilage protection and repair is kind of what its claim is. It's also going to be used for arthritis and joint pains. It is extensively metabolized by the liver. It also has bleeding disorders. It can have hepatotoxicity. So we're going to see drug interactions with other agents that can promote bleeding. All right, almost done here. So magnesium, we've already talked about. How's it work?
Binds to the NMDA.
Yeah, binds to that NMDA receptor on the postsynaptic neuron, and it helps be a plug in that so that we don't have that calcium influx happening and bringing that action potential carrying forward. This is going to be really helpful in folks that have migraines or muscle cramping. We can use it for fatigue and a variety of other conditions as well. Precautions, as we've already learned, cardiac. Side effects are going to be limited by diarrhea. So when patients really want to only take herbals and they're asking which ones to take, if they want to take magnesium, dosing is based on how well their gut can tolerate it. Okay. And then our last one in this class is going to be turmeric. Turmeric is anti-inflammatory and its effects also going to be helping with our arthritis conditions. It has poor bioavailability by itself, and so it needs to be taken with other foods. Again, the product that is a food product that you normally take with other foods is the thing that has by itself poor absorption. It has tons of drug interactions, so it's actually an inhibitor at some sites and an inducer at others. We have precautions for bleeding disorders, those that have kidney stone formation risk, and those that have hepatic injury. Side effects is that we can get hepatotoxicity. There was recently like a 60 minutes or something on hepatotoxicity with turmeric. So doses that are commonly suggested, I would say, by our team were found to also have hepatotoxicity risk. Because pain also will involve things such as procedures, right? When we're talking about, hey, you're coming in, you're getting this procedure done, it's going to be painful, but also I don't want you to have a bleed when you're getting that procedure done. We need to be thinking about different herbals that may increase the bleeding risk. So there's the 5 Gs. Glucosamine is one of those that's considered in that. So all of those increase your bleeding risk. And then fish oil and turmeric, we've already talked about. We'll do it as well. Willow bark is actually salicylate. What does that sound like or similar to? Aspirin, okay. And then wintergreen is methyl salicylate. What does that sound like? Methylated aspirin. Okay? So it's just aspirin essentially with a little extra carbon on it. Okay? So if we have little Miss Nancy, she comes to clinic and she started using an herbal supplement that's a little white pill for her migraines. Ever since she started, she's noticed increased bowel frequency. What might Nancy be taking? Magnesium. Okay? Come on, Nancy. There's tons of resources that are out there. Many are not the best. Okay? So just be cautious when you're working with your patients, making sure that you guys are both using validated and good resources. About herbs, that first one on the list is always my preference. It's something that both healthcare and patients can access. There's an app on your phone that you can look things up. There's good data. It actually links to the different studies that it talks about. So that is probably one of my preferences and is accessible for everyone. From a military standpoint, Operation Supplemental Safety, or OPSS.org, is a good tool and resource. All right, is anyone familiar with this website? Some, okay. So if anyone's ever interested in trying different things or looking at different things, you can direct patients or yourselves to this website. You can plug in, what is in this supplement or over-the-counter product, and it will give you guidance. If you have questions and you want a toxicologist or other expert to look into it, you can actually submit a question to them and they'll get back to you typically within a week, if not sooner. Okay? So I do recommend, they're a great website and resource. If you have a patient who's like, oh yeah, I take this random thing, it's called K2 and I don't know anything about it. And you're like, oh, okay, someone knows what K2 is. Okay, so all of those things, right, you can ask them a question and they can give you kind of that guidance on that. So one thing that we would be thinking about from a pain picture might be kratom. So kratom is not a controlled substance. It is classified as a drug of concern. Per OPSS cannot use it. Okay? How does it work? It's an opioid. It's an alpha-2 agonist. It's a COX-2 inhibitor. Like, it's all of the drugs that we may want for our pain. Right? Treats all those mechanisms that we were talking about. The concern is that it's an opioid. Its dosing isn't linear. So that's another huge concern, is that we really don't know the dosing of it. Recently in our palliative care team, we had a patient who was a retiree dependent patient, so not active duty, but she admitted to using kratom. She said it worked great, and we said, love that. Here's our contract. If you want to get meds from us, we need to work together to make sure that this is safe. This has extensive hepatic metabolism. Okay? Tons of drug interactions. Carries the same risk with our opioids, so we have risk for addiction, overdose, and we also have cardiotoxicity as well. Clinical pearls, when we're thinking about these supplements and herbal products, are not regulated by the FDA for that same scrutiny, making sure that we're choosing products that have a trusted seal of approval for that purity, and then evaluating both patient and medication factors when considering these. So think about the mechanism, or the site of action, right? Is it neuropathic? Is it nociceptive? What drug interactions, precautions such as bleeding risk, and then different side effects that we might expect. Questions? Okay, let's go for break. Come back at 1:35.
Even better. Even better. Unless this is
Robert, how are you tackling this little thing that you
Because they start dropping but she's like, why don't they just yeah, that's she went to go look at the dispenser and I was like, oh, so somebody could take it out. Oh yeah, there's that's what I feel like it is surprising. So then when I went yeah, dude, they didn't sugar for the wins. The only thing is they made every sugar. Yeah. So we did like on my second reload. I thought the girl, I thought she was a drug addict. She was always like this, and I'm like, oh, but she just, yeah, that's okay. I learned that. The lights down, hey, lights down.
It just don't feel like it anymore. But I'm stressing about the exams.
We all failed.
Put it on the bell curve.
That's what I was telling him, was like, we were second I don't know about you. By the time I do my hands, I'm feeling it. You know, I'm gonna double down. That way I can be
So the funny thing with that is like, so like when I was still trying to get compliant with CPAP, there's like different methods. You know, and one of like I hated the full version because like you put it on it immediately, like in my ass would bleed. I want to like scratch it and then like I hate it. I would suffocate it so then they start to try something like some nasal one. The nasal one is like you have some straps you have to tie it around your face and you have to mouth. Because if you have CPAP with your nose, it'll just come out your mouth and open your mouth. So like I tried that, it's been different. So I just went out there. All it does is make a good job.
Are you breathing still through your lungs?
For the, I mean, yes and no. Like, I feel like it's both. I don't like. I couldn't tell you when I sleep. I just know I don't snore. It works. Like, I don't snore. But I couldn't tell you the last time I woke up and feeling fresh. It's probably hasn't been since like a good 2 years. Like I always wake up tired.
You get tired in the morning?
I'm not working. I get up and I'm dragging ass. Hard to think about, but yeah, I'm not I'm tired for the day, but I'm never at a point where like I can just sit here and just like fall asleep behind a wheel and sitting down, I'll fall asleep. Like not that thing. Like you have people who are at that level of social media, they can sit here, not do anything, just like fall asleep because they're so exhausted. I'm tired sometimes.
You take caffeine though? Do you take it?
Coffee, every coffee. So that kind of thing. I drink coffee. Yeah. Yeah, so I can tell like there's days like either I have lesser normal less sleep, or if I guess maybe I was snoring because I'll wake up on a headache and I'm stubborn and shit like
I didn't know how you're surviving.
yeah, dude, I don't know how I'm doing it either. I'm either gonna have anxiety like halfway through this point. See what happens.
I feel like at a minimum I need 6 hours.
I can go 4 or 5 hours. And honestly, like days like I sleeping on the weekends to like catch up. I feel more tired when I sleep than if I wait like I have like 4 to 5 hours sleep. Like only because like I'll wake up, go back to sleep, and go back to rest. Make sure
Miss me yet? I'm fine.
Who are you? Is that Harry Potter's dad?
Harry Potter. That guy's dead.
Didn't work out well.
That's crazy.
remember because there is that 0 to 30 part that it's physiological that shit. So it's still look at the last one. No, it was part of she gets an accident. I think it's
Love my life, I love my job. I love my job. Say it 3 times.
I love the heat. I love the heat. I love the heat.
So, the heat, I love the heat, I love the heat, I love the heat. Actually, I do love it. I'd rather be hot.
See, I can get hot. I can move my body and get warm. But I can only stay so still. Like, let's see. I can only get rid of so many clothes on my body.
Hardest for mine too.
That's probably the start of the start with
I'll get up.
Yeah, we got that. It comes so early though, it's like
The conversation we shared with
wait on you. I would say it if everybody else was.
Waiting on you, Levi. Waiting on you, Levi. Come on, waiting on you.
Alright, we're gonna dive in, talking about topicals.
Yes, sir.
So percentage question, right? Again, I'm not gonna say, what is the percentage, right, on the exam, not what you have to memorize. Okay. So of the US market, it's mainly driven by preference for over-the-counters and natural products. Topical analgesics account for what percent of the 17.8 billion US analgesic market?
64.
Ooh, high numbers.
2%.
27.5.
I love the enthusiasm, love it, okay?
9.
So right, let's think about this, right? When we were talking at the beginning, we were just talking about opioids, right? So knowing that 10% are still coming from these other things that I would say a lot of people poo-poo, like, I don't know, topicals, right? There's still good data for them, okay? So we'll talk about them a little bit. As I already mentioned, topical is getting to local structure, transdermal is getting into the bloodstream, okay? So topical, you're gonna put it wherever it hurts. Got back pain, put it on your back. Okay? Transdermal products, things like fentanyl patches, you're going to put in specific areas where we're expected to have stable absorption. So for fentanyl patches, it's literally the Macarena. You're going on the outer arm, you're going upper chest, you're going outer arm, you're going across the back. Okay? Because my patients typically can't see their back, or maybe they don't have a support person, I just have them do the Macarena. All the time, right? This side, and then we just keep putting a new patch on and moving it. Okay, so transdermal are going to be systemic sites. Again, the location specifically is variable, but oftentimes the chest, arms, some abdomen products as well. Things that are going to increase absorption. So even though I put a lidocaine patch on my back and it's only going to work on my back, if I have a giant thing that's changing the integrity of my skin, whether I have a burn, an injury, or an abrasion, and I put that lidocaine patch on back there, what's going to happen? It's going to go systemically. Okay? If I have increased skin hydration, so that's reducing the compactness of those different skin cells, it reduces that resistance when it's getting diffused. So more hydrated skin will increase the systemic absorption. And then the more blood flow. So any sort of massage, heat, or exercise, okay, are all going to increase absorption risks. Topicals, we think about placebo effect. Okay, a lot of my docs, a lot of my patients will say, it's just placebo. So what if it is? Okay, so placebo means that there's a beneficial therapeutic response to a non-intervention or sham or control. Okay? We know that there is an observed reduction with cutaneous stimulation and, quote, rubbing where it hurts. You're going to get better by touching your knee. I know you don't want to touch your knee, but by touching your knee, it's going to get better. They have done studies, and you do improve. Okay? There's known pain benefit whenever we anticipate there's going to be benefit. They've also done studies on this. So if you counsel a patient, here's some lidocaine patches, I don't know, they're probably not going to get that much benefit. You say, here's some lidocaine patches, I'm really excited for you to use these. I think they're going to work for you. Come back in a month and we'll chat about it. Right? They're going to likely have more of a pain benefit from that. So a lot of motivational interviewing is a big part of pain management. Topical analgesics offer increased patient involvement in the therapeutic process. So if you're able to get a lidocaine patch and throw it on, you're able to get diclofenac gel or menthol and you smell that for the rest of the day, there's different things that are going to feel like the patient is engaging in that discussion and in that choice. Topicals are treating at the site of injury. Okay? Topicals are at the site, they're not transdermal. So at the site, we're going to be looking at a lot of these pieces that had come up when we were looking at that pain pathway. Right? We're trying to nip it right where that injury is. In our skin tissue and in our cells, we have significant activity and engagement with localized inflammatory processes that release excitatory factors and then have functional contact with our different sensory nerves that are then going up to the brain. Okay? An example of these receptors are going to be our TARP thermoreceptors. When we activate V1 and V3, we get this warming effect. When we activate A1 and M8, we get a cooling effect. So when you have these, they warm. Okay? With activation. So bottom line up front summary of our different agents. Menthol has A1 and M8 activation. Are there any V's in it? A1, M8, no V's. So what's going to be the net effect? Cooling. Okay? Camphor has a V1, V3 activation. Warming. Okay? Now we have a V1 and an A1. Now we have a mixed response. Okay? Diclofenac is going to work in a different mechanism pathway through COX inhibition. Lidocaine is going to work with sodium influx inhibition, as you guys know. And then capsaicin is another one that's going to be a V1 activation. So it's also going to be warming. Okay. So with each of these, menthol is an extraction from peppermint. Okay. This is typically going to be our biofreeze. When we think about biofreeze, it's typically menthol products. It has a strong minty odor to it. As we talked about, it's A1 and M8 activation, so it's a net cooling. It also has vasodilation because it's irritating the cutaneous layer as well. So if you put menthol on and you irritate the area and then you put a lidocaine patch on it, what's going to happen? More systemic absorption. Okay? So again, because they irritate the skin as well, any additional products put on will increase in absorption. Menthol products are going to be for minor local aches and pains. Camphor is another one that will be for minor local aches and pains. This one is a warming sensation. Camphor is found from different woods, and it can also be synthetically made. Sarna and Tiger Balm are commonly camphor-based products. This also is irritating that skin. Camphor does have a toxicity that we need to be aware of. So oral administration can lead to seizures, largely in our kiddos. So in the US, we have a max concentration of 11%. You could be curious and go to a random online retailer, I don't know, and look up what things you could buy, and you can easily buy things that are 30+%. Okay? So talking with your patients about those things. Oh yeah, I have this topical, I put it on my foot, my dog really likes it and licks it off right away. Right? Has your dog ever had a seizure? Right? These are things that I'm worried about now. So if they have children or dogs or animals that lick topicals and are prone to doing that, I do steer away from using camphor. Methyl salicylate is found from wintergreen. We already talked about, right? Methyl salicylate is just that little thing that's thrown onto an aspirin. These are going to be typically our Bengay Icy Hot Salon Pass type products. It has a strong fruity or minty odor to it. It's also going to irritate the skin. It's going to be that mixed response in its activation, and theoretically it's also going to have some COX inhibition like other NSAIDs. This one has a 20% systemic absorption. So probably 2 months ago I had a patient who couldn't tolerate NSAIDs at all. He had taken NSAID, he would urinate blood. Like it thinned him out that badly. We gave him some menthol salicylate, same thing happened. Applied it locally to his back, still came in the next day. You know what, yeah, still was bleeding blood. Okay? So a hefty amount of absorption. Because of this, we need to actually avoid methyl salicylate because of its similarities with aspirin. In which population? Children due to Ray's syndrome. What is Ray's syndrome? Aspirin plus some sort of viral illness equals this condition. What's it look like? Bad. Things are failing. Okay, we'll talk about it in a few slides. Also using for local aches and pains. All right, diclofenac. I would say one of the military's workhorses in a topical pain regimen. So we have patches, we have solutions, we have foams. The main one's going to be our gel product. It comes in a 100-gram tube. It's kind of a metallic-y tube. They also make plastic-based tubes. There's a ruler inside the tube that they use. Mechanism is COX inhibition, so we're inhibiting prostaglandins. Less than 6% is absorbed systemically. Okay, so if someone does have renal issues or cardiac issues or other things that would not make them a candidate for a systemic NSAID, an oral NSAID, we could use things locally like diclofenac in hopes that it's not going to get in and hurt those different areas. Mainly we're going to use it for different types of arthritis and acute musculoskeletal injuries. It carries the same 2-box warnings that all of our systemic NSAIDs carry. So cardiovascular thrombotic events and GI bleeding. How pertinent do we think these are going to happen in our patients? Like risky, not risky? Send it.
Depends on the patient, correct?
Depends on the patient, maybe. So less than 6% systemic absorption. Do you think it's going to cause you to have strokes and different things? Probably not. That being said, I've had pharmacy decline my orders because of that risk. Okay, it's still a risk. All right, lidocaine, you guys just talked about this. So we have over-the-counter products, they're going to be less than 4%, and then prescription products that can range from a variety of concentrations. Mechanisms is that locally it's an anesthetic, we're going to inhibit calcium influx, and then we'll have that stabilization of the membrane. Systemic absorption is really going to depend on the dose, the area, and the duration, as with anything. What would be a concern if someone just covers themselves in lidocaine head to toe? Not necessarily seizures. What do we use it for? Arrhythmias. So we're actually at increased risk of arrhythmias. Okay, lidocaine at its max dose is roughly 10% of the antiarrhythmic dose. As with our other topicals, don't put it on wherever there's irritation, wounds, or skin that's not intact. Formulation, so whenever we're doing some sort of cream, gel, jelly, sprays, these are for local minor procedures or conditions. Dosing is going to vary, but it's often 2 to 4 times a day. Our patches, we have generics that are 4 or 5%. We have Lidoderm and then ZT Lido, which is a prescription product. These are going to be used for post-herpetic neuralgia, which is what? Post-herpetic neuralgia. Yeah, like the post-shingles rash. Okay? We use it for a variety of conditions off-label. Okay? Dosing is up to 3 patches. You put the patch on for 12 hours. You have to have a 12 off period with your patches. So you clean the area, you dry it, you open your pouch. You can cut lidocaine patch patches, so the matrix that they're in is stable. You remove the backing. You apply a maximum of 3 patches, and then you administer for no more than 12 hours on, and you must have a washout of at least 12 hours. What would be the risk if someone kept their patches on for longer? And you guys are really good at this. So increasing what? Systemic absorption, increasing risk for arrhythmias. Not a fun way to die. Yeah. Mhm. So like topical sprays are going to vary. Benefit is fairly similar. The risk for systemic absorption isn't going to be as significant as with the patches. Good question. But certainly if you're spraying your whole body head to toe, that's a certainly higher risk. So it just depends on the dose, duration, and area of that. All right, our last one in this list is capsaicin. So capsaicin is found in chili peppers. We can also make it in a lab. It has OTC products less than 0.15% and prescription products of 8%. Is that a big difference? Yeah. How much is in bear spray? Anyone know that fun fact? 5%. So pepper spray is 3%. We can get up to. Bear spray is 5%. And now we have a prescription product for 8%. So we're gonna take a little bit of time and talk about that 8% and make sure that we're using it safely for our patients. Now, how is it gonna help to put hot sauce on your pain? That doesn't sound enjoyable, right? That's what we're doing, right? We're just taking bear spray or Tabasco and throwing it on our pain. So we're doing that V1 activation. We're gonna get a warming sensation. That's gonna cause that calcium influx. We're going to start sending that signal. We're gonna say, yep, keep doing it. So I like to explain it to patients like eating tacos, and we're in San Antonio, so everyone understands that. You eat one taco that has spicy hot sauce on it, your mouth is on fire. Okay, after about 5, it still hurts. Okay, so that's our desensitization, where we're getting functional impairment. It's fine. We're not even chewing anymore. We're just like, this is my life, right? After 20, 30, 40 tacos, you can't feel anything. Okay, so with capsaicin, you have to be willing to go through that pain. Okay, we're getting it to a point where we are essentially exhausting the amount of pain signaling that can be done at that receptor. Okay. It takes roughly 3 months for your nerves to regenerate, so they do have to do that process roughly every 3 months. I usually advise my patients, do it twice a week. Okay, do it twice a week for the rest. Once you're in that defunctionalization stage where you have ablated your nerve effectively, just keep it at a minimum. Definitely do not put it in any of your wounds, in your mucous membranes, in your eyes, and definitely not on your genitals. Of our products. For our OTC products, again, those are much smaller, and then the concentration is going to depend on the formulation that we provide. Our prescription product, that 8%, is in-clinic only administration. I had one of my students 2 weeks ago text me saying that she was at a Walgreens pharmacy, and they got a prescription for capsaicin 8%. She's like, yeah, I had to tell the pharmacist that we're not going to fill it. Okay, this is in-clinic only. For OTCs, they're going to be for minor aches and pains. We're going to dose it 4 times a day for 1 to 6 weeks, doing that every 3 months. Again, we're just trying to get that burn to happen and last. We're going to have to redo it every time that nerve regenerates. Good thing is that it's pretty cheap. For our prescription product, the 2 indications that we have, one is for post-herpetic neuralgia, so that shingles rash that's still there. We can apply up to 4 patches for 1 hour, and again, we do that every 3 months. Why every 3 months? It's when it takes for the nerve to regenerate. Okay? We can also use it for diabetic peripheral neuropathies on the feet. That's a 30-minute application. Again, up to 4 patches. How long does it take to work? So when we're using OTC, it's going to take that duration for that burning to happen. When we're using 8%, it's happening. Okay, so these patients, they're going to feel like the heat of it for about 2-3 days, but the actual ablation that's happening underneath is pretty immediate. So how do we put it on without our patients being very upset with us? We're going to wear gloves. Right? We're going to be sure to wear gloves. I always tell my students, you can always tell when capsaicin is happening because the clinic just smells like hot sauce. When you walk by the exam room, you're like, I bet I know what they're doing in that room. So you wear gloves. Whenever I'm in the room, I prefer to gown. I prefer to wear a mask with goggles. I don't want any of that near me. We're going to mark the area for the patient. We're going to pre-treat. We're going to be nice to these people. We're going to put some sort of lidocaine or emla cream on the area. So we're going to numb the skin. We'll then wipe that off. We'll apply the patches for the duration of time that we need to. We'll remove the patches by rolling them inward on themselves. So the patch is never going to be exposed. Be folded on itself. The boxes that they come in also include a binding gel. So then we put this gel on the area that we treated. It binds and chelates essentially to all of those free-floating surface particles of capsaicin, and then we wipe that off. We had an incident probably 3 years ago where one of our nurses had her gloves on, put the patches on, talking with the patient, opens the door, leaves the room. Next person who comes in closes the door without a gloved hand, got capsaicin on their hand. So they got a lovely trip to the ER where, it's just supportive care. So a lot of just, sorry that happened to you. This is your life. And like I mentioned, right, so heat is still going to be present, but the pain that's underneath hopefully has been ablated. So that heat will be irritated in that layer of skin. Hot showers, hot tubs, sunlight, different things that are going to irritate that area. So again, in summary, we have these different products, have different mechanisms, have different uses, making sure that we're picking the best product for the condition that we're treating. So that brings me to question, why would we pick a product? What would be the most likely reason that you would prescribe a topical for someone? So take a second. Okay, A, B, C, or D, take a second. We'll do a show of hands. Are you going to prescribe it because the patient requested it, because you think that you want to, because it's evidence-based, or that someone else recommended that we do it? So any takers for A? Really? Okay, only 2 people are like, yeah, patient, we love you, okay? B. Okay, some people want to feel like themselves, they know that it works. How about C? Did I talk about any guidelines? No. So I did very briefly, right? But the guidelines that we talked about are very much like, and that's for all of pain, right? So pain doesn't have very great guidelines that say every time use this. So there's very limited evidence-based medicine for use. How about recommendations from a consult? Wait for someone else to tell us. Okay. So provider anecdotal experience is the most common. So they did a survey, and they said that, which of these would you do? Over 60% of respondents said that they have to feel for it. You know what? I've had patients in the past that like lidocaine. I'm going to give you lidocaine. I had someone who used capsaicin. They burned their foot. We're not doing capsaicin for you. Okay, so it's very much personally directed. So what products are you going to recommend? Slampa, Spa Freeze, what are we thinking? We're going to crush your dreams just a little bit, so play along.
Ask the patient what worked well for them last time.
Okay, so what did the patient like? So the patient said, oh, I loved Spa Freeze, icy hot, my favorite. You're like, cool, keep doing it.
Sure. Immediately jump to capsaicin.
So I'm going to crush your dreams a little bit. These slides are not included in your slide deck. So Salonpas. Who likes Salonpas? Tried it, loved it. Some people are like, I don't know what that is. So here's some examples of Salonpas. Salonpas is great. Comes in patches. What do we see about these different products? They all have a little bit of everything. So if a patient says, oh, I love Salonpas, that tells you nothing. Okay, icy hot. Some icy hots, yeah. Okay, and then even looking here, right? So we have this product, right? Menthol 5%, menthol 16%, menthol 10%, and M-salicylate 30%. So yeah, which icy hot worked for you, patient? Right? That's going to really depend.
I've tried.
Camphor, lidocaine. All right, Bengay. Any Bengay takers? You? Sorry to crush your hopes and dreams. But surely, Bengay Sport. Bengay Sport, really good, right? Anyone? Look how cool Bengay Sport looks. Alright, after cream. No takers. We already know that I'm going to crush hopes and dreams today. So what are we learning?
Oh yeah.
Tiger Balm. Hey, you're in Tiger Balm.
Yes.
I know what you're down. You're so different.
Yeah.
So what are we learning?
Dose varies.
Yeah, so branding is a whole different thing. So whenever we're talking to patients, we need to make sure that we're talking about exact chemicals that are in there. What medications are in that product? I'm glad you're taking Aspartame. Is it a red box or a blue box? I can't even say double B's. Okay. All right, Aleve. What should be in this product? So Aleve specifically is the brand name for naproxen. Okay. Did I talk about naproxen as a topical? No. So we have this one, which is menthol and camphor, This one is menthol, and this one is diclofenac. Very different things. Okay, how about Advil and Motrin? What should it be? Ibuprofen. Okay. Advil are a combination of these products. So what happens when we have camphor and menthol that are also topical irritants mixed with camphor, which can also cause what? Toxicity, leading to what happens to my little dog Fido when he licks my leg? Seizures. Okay. And then we also have M-salicylate, which is an NSAID, which already has decent systemic absorption. Okay. So Advil topical targeted relief came out about 2 years ago, one of my least favorite products for this concern. All right, Tylenol, what should it be? Acetaminophen. Did I talk about acetaminophen? No. Lidocaine, and then a lidocaine with menthol 1%. So this all being said, clinical pearls for topicals, evaluating both your patient and the medication factors, weigh risks and benefits, prioritize using FDA-approved ingredients, so you could potentially compound different things with non-approved ingredients, and then limit it to a single agent. Right? Don't have camphor and capsaicin and menthol and diclofenac and M-salicylate all in the same product. Try to pick one. Questions on topicals? We love them, we hate them, we're like, come on.
Spam.
Down around my day, we're still loving them. Okay. The last day that I come back on, I believe it's the 9th, after I believe GI exam, I come back that afternoon. I'll be doing a partial review at that time. I'll bring topicals that you guys are welcome to try. Okay. All right. We're going to move on to NSAIDs. How do we feel about NSAIDs?
Great.
Great, right? So a lot of the guidelines, even though they don't really say anything, typically on NSAIDs, they're like, maybe. Sure. What types of pains do we think NSAIDs are going to be helpful with?
Low back pain. 800 milligrams.
Neuropathic, nociceptive, somatic, visceral. Somatic. Okay, so if I give you a case of someone and their stomach hurts, and how do we treat their stomach pain? Not NSAIDs. If I give you a case of, oh no, their peripheral neuropathies are stabbing and shooting, it's not going to be an NSAID. Okay. So NSAIDs can work in a couple different areas. For example, in the transduction area, we do have prostaglandins down there, so NSAIDs can be helpful there. In normal pain pathways, okay, we have a cellular injury. We have an enzyme that takes that injury and creates a rocket. I tried. See, you guys, I just need to pause. Creates AA, right? That then makes our prostaglandins with the enzyme of COX. There's different areas where COX is located, and it's specified based on whether it's a 1, 2, or 3 type enzyme. They're located in different areas. COX-3 specifically are in the CNS and helpful for temperature regulation. That's not really one of our pain things that we're going to focus on. COX-1 and 2 are going to be the things that we look at and the things that we think about for side effects. So with NSAIDs, we are inhibiting that COX enzyme, so prostaglandin synthesis is not happening. It comes in a ton of different preparations, depending on which NSAID that you're choosing. NSAIDs can be used for a variety of things, as we talked about, so mild to moderate painful conditions, and then we can have inflammatory benefits as well. We do also have eye formulations, so eye drops, that we can use for different things with our NSAIDs. These are the main NSAIDs that we're going to talk about, and we classify them based on how selective they are to inhibiting certain types of these COX enzymes. Okay, so some are going to be much more COX-1 selective, some are going to be much more COX-2 selective. And knowing their COX selectivity is going to tell us what side effects they're most prone to cause. When we inhibit these enzymes, COX-1s normally are found within our mucosal lining. We inhibit that, what are we going to be at risk for? Ulcers. Okay, so things that are more COX-1 are going to cause more what? GI ulcers. Okay. COX-2s are involved in vasodilation. So if we're no longer vasodilating, we're vasoconstricting. That could lead to what? Cardiac issues, right? So I'll get to the net effect here in a second. But our box warnings, all NSAIDs carry 2 box warnings. So GI bleeding and cardiovascular thrombotic event risk. This applies to all NSAIDs regardless of their COX selectivity. Okay? We're smarter than what the package insert says, and we know that some are going to be more riskier than others based on their selectivity and based on where those NSAIDs are. The net effect is going to be dose dependent. So the lower dose NSAIDs are going to be antiplatelet. So what's a super common thing that folks take as an antiplatelet? That's an NSAID. Baby aspirin, right? 81 milligrams of aspirin, low dose. It's just for antiplatelet properties. Low and moderate dose NSAIDs are going to help with pain and fever. High dose NSAIDs are going to be for inflammation. So usually, if someone has chronic low back pain, they'll be on a moderate dose of an NSAID. But if if you just tweaked your back, you did something, you had to help your buddy move, your back's going to be flaring. You're going to have inflammation. At that time, what are you going to do? Higher dose for a short term. Then you'll go back down to just that pain benefit. So thinking about this, these box warnings and where these receptors are working, right? These different enzymes. So the more COX-1 that we have, the more GI risk. The more COX-2 we have, the more cardiovascular risk. Our non-selective, our most non-selective that we will say is going to be naproxen. Things that are going to increase our risk for GI complications. So certainly our more COX-1 agents. NSAIDs that are acidic. So things like aspirin and ibuprofen, by design, are acidic. You take them, they locally are going to irritate the stomach. So it's just a topical irritation. Mechanistically, though, they also have COX-1 properties. They're also going to reduce that lining. Things that are going to increase your risk for GI complications: elderly, those that have a history of GI ulcerations, those that are using anticoagulation or antiplatelets, if folks are using systemic steroids, or if they're using high-dose NSAIDs. Based on the number of risk factors that they have, we'll classify what their GI risk is. If someone has had a historical complicated GI ulcer, by default, they're high risk. Okay? You had a GI bleed, you were hospitalized, you got transfusions, you're high risk. What can we do to minimize risk? We can either use a different drug, specifically, more COX-2. Okay, so we could use more of a COX-2. Forgot to say. So COX-1s are going to hurt the GI. We have one stomach. COX-2s, heart. And it kind of looks like a heart. Okay, like you can see it, maybe. Might help you. Okay. So we can either use more of a COX-2. That doesn't hurt the stomach as much. Or we can use GI protection. Okay, the two categories that we can use are either going to be our PPIs or things like cytotec. So PPIs would be our azole agents, not our azole antifungals. These are going to inhibit that pump that's going on in the stomach, suppressing that acid secretion. We can take these either once or twice a day. And just being careful that when using PPIs, we do also reduce the absorption of other different medications and nutrients. Things like cytotec or misoprostol. So this is an analog to the prostaglandins that are naturally within our GI tract. It's going to be dosed 4 times a day. Typically, that's not why we like it, but also because it has a boxed warning due to the fact that it induces uterine contractions. So women of childbearing potential should not get this. All right. When we think about when to add GI protection, if someone is high risk for GI issues, they should get GI protection. Makes sense, right? If someone's also getting an NSAID and they're on aspirin, they also should get GI protection. If they're moderate risk but not on aspirin, it's a risk and benefit. If they're low risk and not on aspirin, you don't need GI protection. Questions on when to add GI protection? All right, we're going to start mixing in cardiovascular risk. So those that have hypertension, heart failure, if they have any sort of prior MI or related signs and symptoms, recent CABG, different stentings, or again, if they're on high-dose NSAIDs. So now we can take what we learned from GI and from cardiovascular to determine which NSAIDs we should use. So if someone has low risk of GI or moderate risk of GI and they have an average cardiovascular risk, a healthy person, pick any NSAID. Relatively healthy, pick anything. If they have high GI risk, we're risk for bleeding, we don't want a COX-1. So we're going to pick Celebrex, our most COX-2 selective. If someone, their stomach's fine, but now they have cardiovascular risk, whether or not they're on aspirin, we're going to put them on a non-selective. So equally COX-1, COX-2. So naproxen. If they have high risk for both, we're either going to avoid NSAIDs altogether, which I would say is most commonly the answer, or we can do a low-dose COX-2, so celecoxib. We can put it all together, and we can see what NSAID we need to select and whether or not we need GI protection. Have a case in a few slides here. Other side effects and considerations we need to think about are going to be renal. So NSAIDs actually constrict the afferent arteriole in our kidneys. What things dilate the efferent arteriole? ACEs and ARBs. Do we think that could be a drug interaction? Probably. Okay, so that's a risk factor. So if they've been on NSAIDs chronically, high-dose NSAIDs, if they're volume depleted, if they have heart failure, vascular disease, diabetes, if they've had shock or sepsis, lupus, advanced stage, and then our ACEs and ARBs, hydrochlorothiazide, all those different products as well. We can get things like dizziness, edema, LFT elevations, cartilage repair reduction. So often in folks that will get like screws into the bones, especially in the spine, neurosurgery will say that we cannot use NSAIDs because we need to make sure that those spines fuse to those screws. So that can be really difficult for some of the patients that we get in clinic to not be able to use kind of that gold standard treatment for their pain. Renal injury and impairment, and then GI upset, also dyspepsia, so about 15% of folks are at risk for that. Folks that have had a history of GI disease, H. pylori, SSRI, smoking, or alcohol use are going to be more aware of having that concern. Hemorrhage or any sort of bleeding, again, that's a COX-1, and then any sort of clotting is going to be a COX-2. So we're going back to good old Scott, right? These folks are going to make an appearance. So Scott, right, 48-year-old, moderate chronic axial low back pain. He's always just wanted to tough it out, hasn't really tried anything. Could we give Scott an NSAID? So axial pain, is that an appropriate type of pain for NSAIDs? Yes. He has moderate pain. It's been chronic. Are those also appropriate things for NSAIDs? Yes. Okay. So you know what, Scott? We can give you an NSAID. What other questions or things would we need to know about Scott before we recommend one? Any GI issues? Oh yeah, you know, I get a little heartburn, and I just love tacos, it's fine. I get by just a couple Tums, I'm good. What else? Is he on any blood thinners, coag? Nope. I don't like pills, why would I take that? What else? Does he have hypertension, right? Has he ever been diagnosed with different cardiac concerns? Kidney issues. Good. Okay. Do they utilize the healthcare system, right? If we don't have a good history on Scott, but his whole family died of cardiovascular complications and he hasn't been to a doctor in 20 years and he's overweight and doesn't work out, probably not going to pick one that's a high cardiovascular risk. So keep thinking about some of those things. So your exam questions are going to be similar to this, but certainly with a question. Right? So all these cases don't have questions on the slides. Okay? But they'll be very similar to these, outlined fairly similarly. I'll make it fairly clear. chronic, axial, moderate pain, right? I'll spell it out for you guys. Additional considerations with NSAIDs. So avoiding if we're anticipating surgery. Why would we avoid NSAIDs if we're going into surgery? Bleed risk. Bleed risk. Pregnancy we'll talk about here in the next few slides. Caution in many different situations and scenarios. So asthma or nasal polyps, we'll talk about with aspirin is most commonly going to cause this concern, but it's a NSAID-induced asthmatic condition. Uncontrolled hypertension, CHF, GI, and cardiovascular concerns as well. So NSAIDs should be avoided if infertility due to implantation. Why? So if my little egg won't latch on in my uterus, why would my uterus be impacted by NSAIDs? Prostaglandins because mucosal lining. So I no longer have a mucosal lining, or not as robust of one. Okay? So in some of my women who are trying to get pregnant, we'll talk about other options that aren't going to have that concern. Okay? Bleeding risk. So due to these bleeding risks, NSAIDs should be limited to no more than a 48-hour duration of use in the first and second trimester. That means I have a headache today, I can take an NSAID. Okay, I can keep taking an NSAID for 2 days. Then I have to do a washout. Okay, so you can use NSAIDs, but they should be used sparingly because we don't want to have increased bleeding risk. We also need to avoid NSAIDs during the third trimester because we don't know when you're going to deliver. We don't want you to deliver and there to be a lot of blood. Typically doesn't go well. The other thing that NSAIDs do with their prostaglandin pathway is with this ductus arteriosus. Right? So NSAIDs inhibit prostaglandin synthesis. If we close this ductus, which is naturally kept open by prostaglandins in the babe, if we close it, now we're going to have pulmonary hypertension in our newborn, or in our babe, in utero. NSAIDs can also lead to kidney damage in our in utero kiddos. However, if it's time for delivery, but maybe we don't want to deliver, we can use NSAIDs to suppress delivery. So tocolytics are going to suppress different contractions that are going on at time of delivery. We would potentially want to do this in scenarios where we need to get a dose of steroid to mature babe's lungs, and we just need to suppress it a little bit longer. Or maybe we need to get mom somewhere better to deliver this kiddo. Or maybe mom has a UTI. Because of that, her body is responding and having contractions because of that UTI. And we just need to tell the body, here's some antibiotics, here's an NSAID, don't deliver right now. Okay? And typically the body is able to respond to that combo. So good old Maya, right? She came to us, she twisted her ankle, but now she's considering that she might want to get pregnant, or she's actively trying to get pregnant. So if she's trying to get pregnant, she's in her window of fertility, is it something that we should be considering? Yes, no? Some yeses, some no's. So what's the concern?
Mucosal lining.
Mucosal lining is decreased, so potential reduction in implantation. When does that process occur in the course of pregnancy? When is the egg implanted? With a fun fact. Around 1 to 2 weeks. Okay? So, sure, if tonight's the night, great. As long as you're not taking it in the next few days. Okay. What if Maya is pregnant?
How far along?
How far along? Okay. How's that going to change?
2 months.
So 48 hours of use.
Third trimester.
Unless third trimester, what's the risk? Bleeding with delivery. Okay. COX representative of, I would say, maybe 20 more minutes of slides. We can either break and come back for 20 more minutes, or we can push through.
Push through. Push.
For this. Alright. So NSAIDs. Here are our different NSAIDs. Okay? We have our most COX-1 to our most COX-2. We see differences that some are available over the counter, some are available as injectables, some have a really short, and some have a really long half-life. Okay? So if I was asked for you to pick out any one of these things based on these characteristics, right, which of the following has the most or the least? Things that have highlighted are the most. Right? If someone's getting surgery, we care about the most. Or a car accident, they need to have their brain cut out of them, but they just took meloxicam.
That's tough.
Right? So now we're going to go through a select number of these. So starting with more of our COX-1s. So ketorolac or Toradol, COX-1 selective, it is by far our most COX-1 selective. It has the most boxed warnings. So beyond just the cardiovascular and GI bleeding that all NSAIDs have, regardless of their COX selectivity, ketorolac contains many other concerns. So we have avoidance and bleeding conditions, concurrent NSAIDs, renal injury. We have dose reduction requirements and renal impairments in our elderly, in our low weight, and it has a specific duration of 5 days or less, regardless of route. Someone comes into the ER, they're there for 12 hours, they're admitted, they're sent home, no more than 5 days among all those different routes. Questions on ketorolac?
Ma'am, what would the washout period be? Say if you have someone in the field who's taking ibuprofen, but you want to give them ketorolac, IV. What is there a washout period, or can I just stop that one and start ketorolac?
So question being, is there a washout from one NSAID to starting ketorolac? So ketorolac is going to have the most renal issue and most bleeding risk. And so beyond 5 days, they see that people truly have like renal demise issues. So around 7 to 10 days is where we start seeing that. So it's more of just a risk standpoint. If someone's on ibuprofen max dose every single day, they probably don't have great kidneys anyway. So I would probably even be less willing to do ketorolac for 5 days. I'd probably limit it to 1 to 3 days. Good question. There's been numerous studies with ketorolac. Again, this is not your exam question, but there have been numerous studies with ketorolac. Who's familiar with pushing ketorolac? Okay. What doses typically do you guys remember using? 15s? 30s? So there was a study that looked comparing 10, 15, 20, no, 10, 15, 30 in an ER population. After 2 hours, there was no change in their pain scores among any of the rounds, any of the doses. Why would that be? Think about the different, what the doses mean. So moderately dosed NSAIDs cause what? Pain benefit. Okay, so pain does not change. So we just say 10 milligrams, yeah, that's a low dose, but it's not for ketorolac. So there was no change in ketorolac among any of those doses for pain benefit. Could there be changes in inflammatory benefit? Maybe. All right, aspirin. So aspirin is going to be more COX-1 versus COX-2. The specific thing with aspirin is that it is irreversible mechanisms. So it's going to bind and it's going to stay bound, primarily to what? Platelets. Why is that a good thing?
It's not going to clot.
Because now those platelets aren't going to clot. They're going to be inactivated for the rest of their little life. Okay? How long do platelets live for?
7 to 10 days.
Good. Okay? If someone needs to take aspirin for cardiovascular benefit and an NSAID, they need to be taking aspirin first. Why? If we need our platelets platelets inactivated, why do we need to take aspirin first? Aspirin's going to bind to the platelet. It's going to hug that platelet for the rest of its little life. Okay? If we give naproxen first, naproxen is going to bind to it, hold its hand, and then after about 8 hours, say, bye, it was nice seeing ya. Okay? So we need aspirin to bind it to it first, irreversibly. Okay? So typically we're going to give aspirin about 30 minutes to 2 hours before our other NSAIDs. All other NSAIDs are reversible. This is one of our more acidic NSAIDs, and we do have GI risks with it as well. Good old GG coming in, meeting someone fresh. We have a 76-year-old female who's caring for her grandson this weekend and is desiring to keep her general aches and pains at bay. She currently takes a OTC multivitamin, a calcium and vitamin D supplement, a atorvastatin 40, which is used for what? Hyperlipidemia, cholesterol, MI support. Okay. Baby aspirin and metformin ER 2 grams daily. Would you recommend an NSAID? She a candidate?
Sure.
We're like, sorry, Gigi, deal with your grandson. What are we saying? Can she take one?
Yeah.
Sure. Okay. Why are we a little hesitant? Okay, so there's aspirin. So what might we consider? Yeah, any other condition. So thinking about that GI risk, right? So yes, she's on aspirin. So maybe we need to be thinking about GI protection for her. How should she dose them?
Aspirin first.
Taking our aspirin first. Okay. Does she have any cardiovascular risk history? She has a atorvastatin. Metformin could also think about like our ASCVD and all the new things that we're grading on now, right? So maybe we have other cardiovascular concerns. What NSAID are we going to consider? Maybe Celebrex. Maybe naproxen. Okay, so it really just depends on all those different conditions, right? But probably not going to pick ketorolac or something else. Right? We're not going to pick a class 1 for her. All right. Continuing on. So aspirin, like I mentioned, we can have aspirin-exacerbated respiratory disease or AERD. This is a worsening of the respiratory symptoms in individuals with concurrent asthma, nasal polyps, and sinusitis. Aspirin is also contraindicated in children. So those that are less than 18 that have a viral illness with aspirin plus probably something else, they're thinking it's a genetic concern, can get this Rye syndrome. It's a rare life-threatening swelling of the liver and brain. It is managed solely with supportive care. In excess, we can get toxicity from aspirin. When we look at the relative dosing of aspirin, in adults, we're going to keep it under 4 grams. Beyond 4 grams to 30 grams is really where, nope, can't even do my math right, 4,000 to 30,000 milligrams is really where we're going to start seeing our coma, respiratory issues, and death. Okay? The very first thing that we'll see from normal dosing to excessive dosing is ringing in the ears. That is how we used to dose aspirin. Take this medication until your ears start ringing and then come down.
Oh yeah.
Okay? Might not work as well in our military population. What does this look like? Okay, so if someone does have toxicity, we're going to get a mixed acid-base disorder where we're going to have an increase in our respiratory rate. That's going to be an alkalosis. This piece is not always present in children. We're also going to get a sodium bicarb depletion. So how do we think we're going to treat it? Sodium bicarb. Okay? So With this depletion, we get a metabolic acidosis. We get signs and symptoms where we have an increase in temperature, heart rate, nausea, vomiting, confusion, that ringing that's going on. They're going to feel more lethargic, dehydrated, seizures, and eventually death. There is no specific antidote. It is strictly supportive care. But as you guys already identified, sodium bicarb replacement is going to be a big staple in that. We can use activated charcoal. We can use oxygen and glucose as well, just based on the other conditions and symptoms that are going on. And we can get electrolyte correction as well. Unfortunate thing with aspirin is that it causes a bezoar. A bezoar is that when there's a large ingestion, you get a clump of it together. So it gets really sticky. Not many medications do that. So we get this very sticky aspirin ball in the gut. Okay? So if a soldier comes to you and said, hey, I just took a whole bottle of aspirin, like, admit me for SI, I'm sorry. Okay?
Sure.
They might not have any symptoms right there, but they may be having symptoms for days regarding increased aspirin absorption. So it's really imperative that we take a look at that and manage those cases appropriately. We could go in, down and grab it. The risk is now we have a bleeding risk. So is it going to cause more destruction trying to go in and actually grab that bezoar and pull it back out? Aspirin's everywhere. Okay, it's very similar to many of our topicals that we've talked about. Excedrin is a great thing when folks talk about, oh yeah, take Excedrin. Which one? Okay, there's about 30 different ones. Some of them have aspirin, some have caffeine, some have Tylenol, acetaminophen, different products there. So now we get to meet little Jackson. So Jackson's Gigi's 4-year-old male. He ingested the remaining quantity of his grandmother's chewable orange-flavored aspirin tablets. Yum.
Hell yeah.
What are we concerned about?
Raise.
Potentially Ray's syndrome, right? Did little Jackson just have the flu? What else? Toxicity. Okay. What might he be appearing? What symptoms could he have?
Brain swirling.
Ringing in the ears? Yeah, Jackson's not going to tell us. He's just crying the whole time. So, okay, temperature, respiratory, maybe, right? Not always present in kiddos.
Metabolic.
How do we correct it? Sodium bicarb? What else can we try? Charcoal? What else? Different supportive cares, right? Oxygen, glucose, dialysis if we needed to. Ibuprofen. So there are, again, a few doses that I will have you guys remember. Typically they're labeled by these lovely little stars. So the first one that we talked about was lidocaine patches. How many lidocaine patches can we apply at a time? 3. How long can we have the patches on for?
12.
12 hours. Okay. So ibuprofen is another one that the doses we should know for purposes of your career. When someone says that they're taking ibuprofen 800 Q6, you should know whether that's a high dose or not. Okay. We had a patient who was taking it Q4, like, no problem, this is fine. So we have those conversations often in pain management. We have a lot of dialysis conversations as well.
Took the whole bottle.
So under medical supervision, meaning you are monitoring all their labs, their renal function, everything's going on. They can take up to 3,200 a day. Over the counter, that's 12. In peds, our dosing is 5 to 10 mg per kg per dose every 6 to 8 hours. When we talk about acetaminophen, I'll show you where there's overlap between this peds dosing. Oh, little Oliver.
Not Oliver.
8-month-old male. He has known influenza A. He has general discomfort and is fevering at 104.3. His clinical course is going as expected. Could we use an NSAID for him?
Yep.
I hear some no's. Why not?
Raise syndrome.
Ray's syndrome, specifically with
Aspirin.
aspirin.
Just aspirin.
Can we give him other NSAIDs?
Sure.
Yes. Okay. So we're going to avoid aspirin. We're going to pick an agent. Hey, I already know how to dose ibuprofen. I have a pediatric dose. Okay. So I could plug in my dose, I could calculate what he would get for his dosing regimen. All right, celecoxib or Celebrex is going to be the most, quote, GI protective effects, though it does have theoretical cardiovascular risk. Studies show that in moderate dosing, right, low dosing, moderate dosing, it doesn't have crazy cardiovascular issues. Just as safe as naproxen and ibuprofen. While it does contain a sulfa group, we don't care. We still have an alert that will pop up on our system saying, but this person has an allergy to Bactrim, make sure that you don't do this. And it's overridden every time. So even though it has a sulfa, it's not the same thing as the sulfa allergy that we see with other sulfa components. So in summary, what a lovely review slide of the key points that we talked about. So ketorolac has additional box warnings and concerns. We need to limit it to no more than 5 days. Aspirin has irreversible platelet aggregation. We have that respiratory issue with aspirin and Ray's syndrome, and we also have aspirin-related overdose. Indomethacin, we didn't talk about this. Usually we'll see this in GI procedures. They'll use indomethacin. It has unique CNS effects with it, confusion and different things there. Ibuprofen, we have dosing limits. It is more acidic and locally irritating to the lining. Naproxen is the most non-selective of our NSAIDs. Piroxicam has the longest half-life. Diclofenac comes as an oral prescription or an OTC gel that has low systemic absorption. Meloxicam has a longish half-life. It is more COX-2. And then Celebrex is going to be GI protective, and while it does have that sulfa group, we can still use it in sulfa allergies. To summarize, there's no one-size-fits-all NSAID. We're going to use the lowest dose of NSAID therapy for the desired indication, whether it's antiplatelet, whether it's pain control, whether it's anti-inflammatory. We're going to use it for the shortest duration of time to minimize any sort of complication, side effects from it. We're going to make sure that we keep assessing different risk factors. Okay, what different dosing, which NSAID, what duration do we need to be thinking about, and if we need to be adding on potential GI protection. If one agent is ineffective, try either changing the dose or picking another NSAID. Okay, don't just say that NSAIDs don't work for them. Try something else. There's additional resources that we can see. So one of the readings that should be uploaded is this one from FINERUP. It was from NEJM a couple years ago. Goes through that pain pathway that we talked about, talks about all the different classes as well. Has a lovely picture of kind of where these meds are working in that pain pathway. There's different videos and modules that you can look at, different podcasts, and then those different databases that we mentioned. If you're interested in getting into the weeds on NSAIDs, there are a few slides on these. Many of these were a part of the slide decks previously that I felt bad just taking away from you, but I don't find utility in having you guys know that piece for the exam. Okay. All right. So with that, super top secret. Art's not here. We're going to pick up tomorrow for part 2. Scouts honor. Yes, agreed. We're going to be so excited for tomorrow to come back and do part 2.
Yeah. Hell yeah.
Yeah, great, love it. Part 2, we're going to talk about the rest of our non-opioid pain meds. Okay. Next, and then after that, next week, on Tuesday, I believe, you guys are then going to be doing arthritis, gout conditions. A lot of those treatments are going to talk about the medications that we've talked about for our non-opioids. Okay. Some of those conditions are still going to go into, we might try an opioid here or there. Okay? After you guys do gout, then I'll be back on Wednesday. We'll go through opioids. We'll get through as much as we can. I'm going to imagine that we'll probably do a little bit more on Monday after your exam. I know next Friday and next Monday are bigger exams for you guys, so I don't want to ruin your brains completely, right? So then on the 9th, when I come back, the Monday before your exam, we'll wrap up whatever we have left with opioids, and then I'll do a review whatever questions you guys have, we'll talk about. I'll bring topicals, free for all if anybody wants to try those in class. Questions? If you have questions, I'll be sticking around. But best of luck on your guys' exam tomorrow.